Good afternoon, ladies and gentlemen. I'm Aneil Malhotra. I'm a cardiac risk in the young PhD research fellow, and it's a real privilege to be able to give this talk on ECG interpretation in adolescent athletes. Now, the past decade has seen significant progress in the interpretation of the 12-lead ECG, culminating in 3 sets of criteria that have been mentioned to help identify athletes at risk of fatal arrhythmias. However, these recommendations are based on adult athletes' ECGs, yet it's adolescents that form the largest segment of exercising individuals in any given nation. So those between the ages of 14 and 18, for example, in the UK alone, comprise of 3 million of such individuals, and that increases to 10 million over in the USA. Along with this, numerous sporting bodies are increasingly undertaking pre-participation screening to identify athletes at risk of sudden cardiac death with a health questionnaire, physical examination, and a 12-lead ECG. Furthermore, if one considers the demographics of a large case series of sudden cardiac death in young athletes, albeit through medical reporting of the death certificates, it does become apparent that those aged 17 or less are particularly vulnerable, with the majority of conditions from those that may have been identified during life. So, understanding the athlete's ECG in adolescence is important, and to date, the largest study that's been carried out by adolescents was by Professor Sharma, and I'm sure he's very proud of this fact, albeit that this study is now from the last century, but did consist of 1,000 junior athletes, and following that, the group did study 300 black athletes as well who were adolescents, but Professor Sharma said it was before the criteria were devised. The juvenile pattern is now well established, with up to 10% of those under the age of 14 exhibiting a pattern of anterior T-wave inversion, i.e. T-wave inversion extending up to V4, which could be deemed normal. And this falls to just 0.2% in those over the age of 16. And in studies comparing adult athletes' ECGs, there was a demonstrable reduction in the false positive rates in both white athletes, as highlighted by the grey figure, and black athletes, highlighted by the black figure. However, the issue of the junior elite athletes' ECG and ethnic variations within this group has neither been addressed nor validated in terms of these criteria, and it's important to ascertain whether such criteria are actually applicable to adolescent athletes. And I'd like to share with you some work that was awarded the Young Investigator Prize both in Europe at the EuroPrevent Sports Cardiology Conference and was runner-up at the American College of Cardiology conference earlier this year. And we looked at over 10,000 junior elite athletes who were from the Football Association's pre-participation screening program. So it doesn't matter if you play for Manchester United or Hartlepool United, but at the age of 16, the Football Association here in England and Wales mandates that you undergo a pre-participation screen, which comprises of a health questionnaire, a 12-lead ECG, and, importantly for the study, an echocardiogram. And the 12-lead ECGs were analysed independently by 2 cardiologists, blinded to any pathological findings in terms of the 3 sets of criteria. And the majority of athletes were white, although at nearly 900 black athletes, it still is the largest, or one of the largest cohorts that we report. And the mean age was about 16.5 years, predominantly male, but again, at 500 females, that is a significantly large cohort. Black athletes were slightly larger and had slightly higher blood pressures than white counterparts, albeit within normal range. And both sets of athletes undertook about 12 hours of training that comprised not only football, but also a combination of strength and endurance exercises. And this table compares white athletes with black athletes and also males with females. And what we found was sinus bradycardia and sinus arrhythmia was much more common in males than it was in females, but left ventricular hypertrophy was 4 times more common in males than females, and also more common in white than black athletes as opposed to right ventricular hypertrophy. And those minor criteria that we saw in the amber circle of the refined criteria actually identified atrial enlargement, both left and right, as being more common in black athletes than white athletes, but no statistically significant differences were noted between males and females. And if we consider anterior T-wave inversion, black athletes demonstrated more anterior T-wave inversion than white counterparts, and females did more so than males, and especially when it came to anterior T-wave inversion. But it's important to note the paucity of anterior T-wave inversion extending beyond V2 in males at just 0.8%. Inferior and lateral T-wave inversion was also more common in black athletes than in white. So the take-home messages from here were that black adolescent athletes demonstrated a higher prevalence of T-wave inversion than white athletes in all territories, and females demonstrated more anterior T-wave inversion than male counterparts. And applying the three criteria, so when the ESC criteria were applied, 13% of all ECGs were deemed abnormal. This fell to 4.3% using the Seattle criteria and just below 3% using the refined criteria. And when we compared white athletes, represented by the grey bar, and black athletes, represented by the black bars, a similar trend was observed in all three criteria. Black athletes demonstrated a greater percentage of abnormal ECGs than white counterparts in all three criteria. And when examining the percentage change between each set of criteria for white athletes, there was a 67% reduction between the ESC and Seattle criteria, a 78% reduction between ESC and refined, and a third of a reduction between Seattle and refined. And all these differences were statistically significant. And the reductions in abnormal ECGs in black athletes as well was very similar. And when we examine the proportion of abnormalities for the adolescent athletes' ECGs within the ESC criteria, over half were due to an abnormal QT interval. It's already been mentioned that the Seattle criteria has less conservative cutoffs for a diagnosis of long and short QT syndrome. However, axis deviation comprised over half of these abnormalities. Now, the refined criteria considers axis deviation in isolation as a normal finding, and therefore T-wave inversion accounted for the majority of abnormalities in this set of criteria. But it's well recognized that T-wave inversion in V1 to V3 in those under the age of 16 is a normal variant. But this isn't accounted for in any set of criteria and would have further reduced the number of abnormalities by 20. 36 conditions predisposing to sudden cardiac death were subsequently identified, and 33 of them were correctly identified by all three sets of criteria. There was one case of arrhythmogenic right ventricular cardiomyopathy and 2 cases of abnormal coronary artery origins that demonstrated a normal ECG, but were subsequently diagnosed on echocardiography. So having identified 33 of 36 serious cardiac conditions with the ECG, we can demonstrate a false positive rate that in adolescent athletes occurred to a lesser degree in white athletes than in black athletes, and to a lesser extent than previously reported rates across all three criteria, from as high as 15.5% in the black athlete using the ESC criteria to as low as 2.5% using the refined criteria in white athletes. And in conclusion, there are normal ECG findings in the adolescent athlete that don't warrant further investigation, and there are well-established abnormalities that do trigger further tests. We can also take into consideration the refined criteria's borderline variants of atrial enlargement, axis deviation, and right ventricular hypertrophy, and deem them normal if they occur in isolation. However, accounting for the juvenile pattern, and as well as considering T-wave inversion in V1 to V2 as normal in white individuals, as recommended by the Seattle criteria, the abnormal ECG rate would fall to just 2.1% in adolescent athletes, while maintaining a specificity of over 97%. And I'm sure you'll agree that that is an extremely acceptable false positive or abnormal ECG rate across any screening program. And these are now soon to be published as the new international guidelines. So in conclusion, we've demonstrated that adolescent athletes exhibit similar ECG changes as adults, though to a lesser extent. We've highlighted that black athletes exhibit a greater degree of abnormal ECGs than white athletes, and also illustrated the contemporary guidelines for ECG interpretation, which are applicable to adolescent athletes. Thank you for your attention.